about the endoscopic resection for early gastric cancer. Okay, so we can do endoscopic resection in early gastric cancer. Important. Okay, okay. So in endoscopic resection we have two things: EMR and ESD. Endoscopic mucosal resection, endoscopic submucosal dissection. Okay, okay. So, what are the advantages of endoscopic resection? So, most important advantage is avoiding gastrectomy. So, in early gastric cancer, we no need to sacrifice of stomach. Okay, okay. And major disadvantage is, since it is just resection, mucosal resection. Okay, so incomplete resection and unrecognized lymph node metastasis. Okay, so two things: advantage, avoid gastrectomy; disadvantage, incomplete resection and unrecognized lymph node metastasis. Okay, okay. So we have criteria which all tumor we can resect through endoscopic resection. So there is a one table in Sabiston. So standard criteria for endoscopic resection of gastric adenocarcinoma. So in gastric adenocarcinoma we have two things: intestinal and diffuse. So only intestinal type of adenocarcinoma we can do the endoscopic resection, one criteria. Then second one is tumor confined to mucosa. Okay, then absence of lymphovascular invasion. Okay, and then non-ulcerated tumor. Okay, it should be non-ulcerated and less than 2 centimeter in diameter. All parameters are very important, especially this ulcerated, that is non-ulcerated tumor, and less than 2 centimeter. Okay, this one you can easily remember, like absence of lymphovascular invasion and limited to mucosa. And this you should remember, intestinal type of adenocarcinoma. Okay, only applicable to intestinal type of adenocarcinoma. Okay, so after this they have given the extended criteria. Okay, so in extended criteria they have given the differentiated mucosal tumor without ulceration. Okay, if this is differentiated, so there should not be any ulceration, and one undifferentiated mucosal tumor up to 2 centimeter. Okay, okay. Remember this key two word they may confuse regarding the differentiated and undifferentiated. Okay, so undifferentiated mucosal tumor up to 2 centimeter and differentiated mucosal tumor without ulceration. Okay, then mucosal tumor up to 3 centimeter with ulceration. Okay, remember it's expanded criteria. Okay, okay. And then slight submucosal invasion. The slight was important. Okay, okay. Here the 2 centimeter has increased up to 3 centimeter with ulceration. Okay, and if it is 2 centimeter we can do also for undifferentiated mucosal tumor, in differentiated mucosal tumor without ulceration. Okay, okay. So in EMR we use saline, okay, and snare device to resect it. Here is the picture of EMR. Okay, so we have injected the saline, then this elevated, applied the snare and resected. Okay, so strip biopsy. Okay, so saline injected in submucosal layer, this is asked. Okay, saline injected in submucosal, because you have to resect the mucosa, so saline injected in submucosal layer. Okay, okay. So we can do en bloc resection or piecemeal resection. So en bloc resection is preferred. Okay, in piecemeal resection there is a chance of increased recurrence. Okay, so after the procedure there are chances of positive lateral margin or positive vertical margin. If there is a positive lateral margin, you can repeat endoscopic therapy or close surveillance. Okay, but if there is a positive vertical margin, okay, or lymphovascular invasion or some mucosal invasion, you have to do gastrectomy with lymphadenectomy. Important. Okay, they may confuse with lateral and vertical. Lateral, repeat endoscopy or surveillance. Vertical, you have to do gastrectomy with lymphadenectomy. Okay, okay. Now come to endoscopic submucosal dissection. Submucosal. Okay, so resection of larger tumor and those with limited submucosal involvement. Okay, so submucosal injection of epinephrine with indigo carmine hydrodissect. So in EMR we were using saline. Here we are using epinephrine with indigo carmine. Important. Okay. Since this is more radical surgery compared to resection, so here higher chance of perforation. Okay, compare with EMR. Okay. So endoscopic resection to gastric endoscopic. We have compared the endoscopic resection to radical gastrectomy for early gastric cancer. In early gastric cancer, we were doing two things: endoscopic resection, or we can do radical gastrectomy. So in endoscopic resection, higher rate of recurrence and metachronous lesion, but the 3 and 5 year survival was similar. This is the important one. Okay, and morbidity was significantly lower with endoscopic resection. It is obvious. Okay. So main highlighted point is 3 and 5 year survival was similar to radical gastrectomy in endoscopic resection. Okay. So actually I wanted to tell this, but I thought let's summarize everything. So endoscopic criteria for standard criteria for endoscopic resection of gastric adenocarcinoma, it should be intestinal type of adenocarcinoma, tumor confined to mucosa, absence of lymphovascular invasion, non-ulcerated tumor, and less than 2 cm in diameter. Okay, thank you.